Hi, folks. I'm Rich Lucy, Senior Prevention Program Manager here at the Drug Enforcement Administration's Community Outreach and Prevention Support Section. Welcome to this episode of Prevention Profiles Take 5. Very excited about today's guest. I'm on a bit of a roll here with getting vice presidents onto the podcast. Our guest, I think she's going to be the third in a row, which I'm really happy about, especially vice presidents of this particular topic that we focus on during this podcast. So it's Dr. Sherrá Watkins, University of Utah. Let me tell you a little bit about Sherrá. Dr. Sherrá Watkins is a renowned clinical psychotherapist and certified coach with a decade of experience in mental health and wellness. Currently, she serves as the Associate Vice President of Student Health and Wellness at the University of Utah, dedicated to improving access to counseling and addiction services for historically marginalized populations. With 4 degrees from East Carolina University, including a Ph.D. in rehabilitation counseling and administration, she has received personal honors from Zeta Phi Beta sorority and professional recognition in the ECU Leadership Awards 40 Under 40 inaugural class. Dr. Watkins is a sought-after keynote speaker and author of the acclaimed book Healing in Review, offering invaluable tools, knowledge, and journaling for readers to reflect and record their healing process with counseling or coaching. And with that, Sherrá, welcome to the podcast.
Thank you for inviting me. It's so good to be here.
Absolutely. And I know, I just read your bio. The questions that I have for you are going to dig a little bit deeper into some of those topics. So before we get into those questions that I have for you, though, let's start with you telling us a little bit about the University of Utah.
Sure. The University of Utah is located here in Salt Lake City, Utah. Beautiful scenery here in the desert mountains. We have about 36,000 students from all over. And what's very unique about our students is that they are very driven when it comes to a variety of different types of majors and degrees. What I have been able to see since I've gotten here, this is my second year now, is that we have some prominent degrees in engineering, which is very lucrative for this university. But we also are very much allied health and academic medical center. Our health sciences campus has 6 different areas, from nursing, OT, PT, our school of medicine, and also it has our dental school. And so, which is very unique when you think of an R1 institution to have 6 different areas, including an engineering, including a law school, all at one larger university. So it's very diverse student population and a wide variety of students that we serve from all over the U.S. One interesting fact is about 60% of our students come from right here in the state of Utah.
So I have a little anecdote, and I'd like to get your perspective on this. So several years ago, both in my previous agency and once here at DEA, I've been out to Utah for the state's Prevention Summit. A good friend and colleague, Craig Ph.D., who worked for the state there, had brought me in, and I was doing a typical workshop on preventing alcohol and drug misuse among college students. And I started off, I figured my icebreaker was going to be this for the very large crowd that was in that session. I said, I'm not really sure why they invited me to come to speak here in Utah, because we know that students in Utah don't drink, right? And that the audience erupted in laughter. And I think it was like, that was my way of, I kind of got them at that point. I had them. It was sort of like an inside joke, but I think it was a bit of a breaking of the misperception. You mentioned 60% of the students, are from Utah. Do you find that as well? I mean, that there's that misperception, well, Utah must not have that big of an issue.
There's a great misperception because when you think of Utah, you also think of the LDS faith,
Right.
also sometimes called Mormon, but there's a preference to use the term LDS.
Right.
And so with that perception, we know that from that dominant religion that they do not drink caffeine, they do not smoke, they do not drink. And so many of their students do go to this institution, which is the flagship of the state. And that misperception is misguided. Now, When you compare us to national data, our numbers are lower compared to national data when it comes to the use of alcohol, tobacco, and other drugs. But it
Yeah.
is very much untrue to say that they're not doing anything at all. So
Yeah.
that it's an untruth.
Yeah. Well, I'm glad that we had that little bit of levity there, but the truth there. I mean, there and kind of educating folks just on that, like you said, a misperception. All right, so let me get into my first question. So earlier this year, NASPA, a very strong partner of DEA's as well, with their strategies conference and our Red Ribbon Week PSA contest, which is currently underway. Shameless plug there. Earlier this year, they had the online event with a whole host of other national associations, and it was called Wellbeing in Higher Education. And I tuned in as much as I could throughout the course of that week, and I caught your session that you had done. And you quoted your grandmother during that session with one of her sayings, which is, make it make sense. How does that philosophy guide you in your work?
Number one, I love my grandmother. Rest in peace, Maxine. I take that adage both personally and professionally. As being a first-gen student, I often use in my way of approach to not to be mindful not to speak from a place of privilege. Even being
Okay.
first gen and sitting in this seat, that saying that my grandma raised me with, to make it make sense, we need to speak when building policies, when creating programs and services, that we need to speak to the need of clarity and purpose in everything that we do. And so it makes me challenge myself each and every day that we are creating systems of change to implement and truly serve the people and populations that we're meant to service. Are we truly creating systems of change that we're meant to implement? Or are we just creating things to be seen, to be heard, to be innovative? But when we're looking at what the current needs and gaps are in, we have to do it transparently. We have to do it with intent and purpose. And so one of the questions that I ask myself is, does this intervention, does this initiative genuinely meet the needs, for example, in this setting, the needs of our students? Does this intervention or program or service, particularly those who may be historically marginalized, meet the gap of this particular center where they're not showing up? And are we using resources in a way that is equitable and impactful? So when I use that term, make it make sense, is the data supporting the decisions in a purposeful way?
I love that you said do it with intent and purpose. I mean, it's people who have seen my workshop over the last couple, 3 years with prevention with purpose. I talk about the fact that prevention's not random. It needs to be done strategically, intentionally, and with purpose. I loved, so just by hearing that, I love your grandmother Maxine too. I love the quote, because when I heard it, the way it resonated with me, it was a different take on it. I have brought up my mentor, Fran Harding's name plenty of times on this podcast. And she always would impress upon the staff, whether it was back in our home state of New York or down here in DC when she was director of CSAP, that we need to be very mindful about the language we use, the terminology that we use, the way in which we communicate. And I always took a little bit of a tangent on how she would say it for her family, but it was, for me, I always wanted to make sure that I talked about what I did so that my mom understood it. And so, like, I can't talk to my mom and my sisters about universal, selective, indicated, primary, secondary, tertiary. I mean, that's right over the head, right? So I boiled it right down to, Mom, my whole career is to try and get kids and college students to not use drugs. There you go. Now we could, now she understood what I was doing in the nation's capital. So I love that sentiment of make it make sense, because that really can guide you in everything, every aspect of what you're doing, whether it's from data to budget to evaluation to implementation. I see that going in so many ways.
So we have to be mindful with the different terms we use, whether it's wellness or well-being, or upstream prevention or
Hmm.
population health, that how are we applying these terms in everyday language? For example, with the setting that I work in within higher education, these students are coming into this setting for the very first time. Many have never making their own doctor's appointment for the first time, knowing how to read an insurance card, or even understanding how to navigate a healthcare system. And I like to really tell our faculty and staff here on campus that the different departments, from the University Counseling Center to the Office of Disability and Access to our recreation, is a healthcare system. And
Hmm.
students sometimes do not know where to start. And so, how do we help our students in using, as we're saying, to make it make sense, how to use navigation? And I know I'm not well. Where do I start at the beginning?
Hmm.
And that means using language of saying, if I'm unwell, does it really matter what door I enter into first? Can you help me to know where to go, even
Hmm.
if it's the wrong door? And so language is very much important. And we need to ensure that in the language that we're sharing, that as it has been prior to, I would say, maybe in the last year or so, we've really been trying to move away from it, that we're not pushing all students just to one door, which has been counseling, that
Hmm.
prevention and holistic wellness, or as we like to say on this campus now, that healing is creating your own personalized pathway for you having the agency to choose what that looks like.
Hmm. Hmm. Just like treatment,
Yes. Yes.
just like prevention now. I mean, it's meeting students where they're at. And I loved you brought up the door analogy of, we've been talking about no wrong door for a while now. And that's the whole idea of everybody has, all the different stakeholders on campus have a role in this. So, and you've named some of them. So I just love how you've brought that, all together. My next question deals with stigma. And, so I've been in this field now since, all right, 1991. And so stigma's been around for a long time. I mean, it's like, you know, I just can't believe we're still talking about it 3 decades later. But, and I know one of your research interests really does center around stigma as it relates to mental health and substance use disorders, especially among African Americans. Do you think that we've made any progress in reducing stigma, especially among college students, and what challenges do you see still remain?
So I think there's a 50-50 question. I'm going
Mm-hmm.
to always start off positive. It's like the Oreo effect.
Okay.
Yes, we have made some great strides and some great changes. And I think that, to be completely honest, and I'm going to be transparent, some of that has been because of us, and some of that has been because of the use of social media and
Right.
media. They
Okay.
have they have, in a way, social media and media have watered down, and through the use of showing openly what does counseling and psychology and mental health look like, and it has become normalized that it is okay
Mhm.
to be not okay. It's okay
Yep.
to have your faith in your counselor too, and your coach and your life coach. And so what I have seen from these last two generations, in a good and also bad way, is that they want their microwave fixes. They want to be able to have their coaching and their counseling, and they're going to go and seek help. And so that is the positive piece. They're not afraid to go in to talk to someone, to seek medication, to get the yoga, to go to the group supports.
Mhm.
The parts where, when we're looking specifically from our African American populations, is that we still have to look at that population. That is a collectivistic population. in simple words, because we're going to keep it simple, that is a group think population. How I learned to overcome, to process problems, to push through, to even to think about what options I have to cope, to do self-care comes from what I see in my environment immediately, and also the immediate one step out as far as within my community. And so if I have been given permission to utilize a variety, I do this as far as like I call the rainbow, a variety of tools, then I'm empowered to do so. But if I've only been told through groupthink that I'm supposed to be strong, push through, or one person in my family went to counseling and had a bad experience, or the only type of
Mm.
counseling I can go through is through the church, then that's the only mechanism I may be limited to. And so there's a great stigma of, if I reach out to help or tell my family's business, then I'm not strong. That type of stigma is still swirling around in the African American community. And so that mentality comes onto the college campus. And we also still see it. So even if they feel empowered to say, I'm going to try something different because I'm not at home anymore, if one student has a bad experience in our counseling center, they take that story back to that group and tell about that experience. And what I've
Mhm.
seen is that when I met with our Black Student Union, I heard stories from that group, and I asked, well, when did that happen? And it was the stories of the seniors that happened from years ago. And
Mhm.
so trying to restore and to do restorative practices to those African American student populations, some of those that repair work is not from current issues. It's from stories of students who encountered egregious situations from semesters and years past. And so that's the hard work. Is that
Mm.
many of us on the campus that sit in leadership positions, directors, and even counselors who's out there doing outreach and education, this is systemic work, meaning that you have to work with the immediate group. You also have to work with their advisors to those student organizations, and you also have to get beyond the walls. You can't do counseling within walls, is how we typically like to see it. And so you have to be creative and innovative, and also get beyond your comfort zone. And
Mm.
so the challenge still remains. How do we do counseling beyond walls? How do we do it based off of how the APA and ACA tells us that we have to show up as sometimes clinicians, and we're not supposed to go to certain events with them because that may come off as being friendly, when we know that they have to see us as being one of them in order to trust us. But our
Mm.
ethics says that, what does that big word, transference, countertransference look like when there
Mm.
is a fine line? But they still don't trust us because it has been set up within a medical model. And his history has told us that you took my power away. You experimented on me and my ancestors.
Mhm.
You didn't give me medicine when medicine was available with vaccines. And so
Mhm.
we now have decades later do intergenerational trauma. Why should I now trust this new system of where you still want to mess with my head and heart? And so these
Mm.
are systemic issues that we can't displace now because we want these same students to trust us. And the last challenge that I will share with you, Richard, is we have some miscommunications with African Americans at all. Any historically marginalized populations that has encountered intergenerational trauma, when you look at that research model of intergenerational trauma, there's a visual depiction of it by, I can see the name of the researcher. I'm going to kill myself because I do this all the time, but it's there. I can see it. When you go through the model, there is a trauma that is depicted on the ancestors, and there's four different variables that happen to those ancestries. But I'm just going to skip down to the middle part of it. From one of those impacts, something happens psychologically,
Mm.
and that one impact is called resilience.
Mm.
That initial ancestry, those ancestors that the initial impact happened upon, they was embedded with resilience. And from that embedded resilience, we now have what we call reciprocal resilience. So we got good and bad. Psychological trauma that is regenerated. We also have resilience that's reciprocated. We also have genetic coding that's reciprocated. But when we have now us medical professionals, psychological professionals, says that we need to do resiliency building and training and workshops for historically marginalized BIPOC populations to build up resiliency. That tells me that we haven't done our research. You don't need to give these populations resiliency. I already have it. They already have it. What you have to go back is to what I first said. Have you given them permission to utilize it? Because I've been taught that I don't have permission. You may also need to give them new tools that they may not have been having in their toolkit. And that's the difference, is that we have many professionals like, let's do resiliency, but you don't know your population and you don't know your research. And so we're causing more harm by telling many African-American students, you're not resilient. I was born resilient. It's in my genetic coding.
Right. Wow, there is, I was furiously taking notes, lots to unpack in all of that. And so I want to go to two things. One, I often talk in my workshops about the N of one, and it related to what you had just said. It was one student comes back from a counseling session or even an academic advising session and had a bad experience. And, it's that goes to another student, to another student, to another student. Is that what you were kind of getting at with that? The experience of one seems to influence so many others.
Yes.
Yeah.
And it does. And one of the unique analogies that I remember hearing when I went to NASPA, the very first one that they had right when after COVID and they opened it up, is that when we do not use our deductive reason to stratify the data by asking what we call the additional question. And so students don't know to ask the additional question, which is, what made that experience bad? And so sometimes it's as simple as they mispronounced my name. And when I corrected them, they ignored me. We have forgotten in our culture that names have purpose, have meaning, and that small to them mistake is minute. And so for many students, it wasn't minute. Whether it was a name mispronunciation or my full body figured couldn't fit into a seat, or there was no pictures or magazines of someone who looked like me on the walls or in the magazines on the table, we have forgotten that students need to be seen in that space. And so they're going to take that depiction, whether visual, auditory, or subjectively, back to their peers of, if I couldn't see myself there, you're not going to see yourself there and feel accepted either.
The other concept I wanted to mention on this issue of stigma, which I want to ask you, because to me, I look at it as this issue as being universal. It's that people just don't want to talk about it. And I thought I heard you say that was part of the groupthink of, you just need to be strong, put your head down, barrel through. And then I heard you talk in a different piece, and I still think this has something to do with the stigma issue, is within the African American community, is there I'm trying not to overemphasize it, but a general distrust of health care? I mean, I know you brought it up, and for many people, they maybe only have heard this for the very first time when we were going through COVID, and it was, those of us who have read the history and know about the Tuskegee Airmen, and there was distrust of the vaccine. And I think that related, does that also relate to other parts of health care, like mental health, seeking help for counseling? I mean, I don't want to overgeneralize it, but that's how I am interpreting it.
You are completely spot on. Let's just take it across the continuum of wellness. So when we talk about what COVID did was that it unmasked medical distrust for the BIPOC community as a whole, for
Right.
both health, emotional wellness, and mental health.
Mhm.
And for those, when we're looking at intersectionality of this topic, meaning that I may have a mental health issue and I may have a chronic disease, COVID exacerbated this cause astronomically. So
Mhm.
before I came back into higher education, I worked with special populations. I worked, and which means that I still never left higher ed. I was just on the medical side in an academic medical center.
Mm.
And I give you a quick example. The last population I worked with was patients living with sickle cell. So
Okay.
when COVID hit, at the same time, we had multiple epidemics. We had
Mm-hmm.
COVID, we had the opioid epidemic,
Right.
and then we had social justice.
Mm-hmm.
So I was living in Charlotte, North Carolina, working at a large medical center, and I had a young woman and a young man that was going to UNC Charlotte. One was, as I like to call, a baby freshman, and one was a graduate student. So we
Mm.
had two different types of ways in which they were trying to navigate. Someone who was very brand new to the area, and someone who was, a semi-expert.
Mm-hmm.
What COVID did was, in shutting down access to the emergency room for people living with sickle cell who also were adherent to opioid medications for their pain management.
Mm-hmm.
My patients also were living with a hidden disorder of mental illness because they're more predisposed to mental health.
Mm-hmm.
They were called drug seekers. It was hard for them to get additional accommodations to work from their homes, their residence halls, because they were immunocompromised. And so we saw multiple exacerbations happening at the same time of trying to navigate multiple systems that were co-occurring. How do we work within a university systems of trying to get accommodations, and professors like, well, how can we trust that they can get the work done, take the testing, when all those different types of issues? We have a large institution of, well, how can we give these large quantities of opioids? And at that time, we had just started. I had to work with my chief to start a Suboxone clinic because that's how we had to transfer to, because we couldn't get methadone, couldn't get the medications. And so what was the safer route to get them adequate pain treatment? And my
Mm-hmm.
chief had never prescribed Suboxone before, and then had to navigate the insurance realm because why are we prescribing Suboxone to sickle cell
Mm.
patients? And so it was a very interesting time for me as a clinician, as I'm triply licensed, to help navigate our patients through mental health, substance use, pain management, higher education accommodations. And I was wearing multiple hats. So when we're talking about stigma, I was encountering stigma for my patients in emergency medicine, inpatient, and also higher education. And
Mm.
all they wanted to do was be well.
Right.
That was it.
Mm. Well, I want to pivot um, a bit and into the workforce area. So the strategic prevention framework, I reference it frequently during these podcast episodes. It identifies cultural competence, and now we have added cultural humility as to part of that conversation as one of its two underlying foundations. What are some ways that you think the prevention field can work to increase diversity, equity, inclusion when it comes to new professionals as we're trying to build up our workforce?
Number one, I always say, what is the baseline? What is their baseline knowledge that they're coming in with? And not necessarily just coming from some type of national test. That is one way that will give us a snapshot. I do think we have to do our due diligence that when we are hiring these professionals in their first employment setting, is there a standard that we're setting to say that we are assessing their competence in DEIJ when working with this set population? So we now have a framework that we can say in this setting, higher education, community-based, jails and prisons, whatever it may be, that we should have a standard. And we should be able to sit there and say that based off of these standards, this is where we know that this person's baseline is. So that way it's a part of their annual review. Because if we don't have a baseline, we have nothing to assess year over year. And we have nothing to incentivize to actually have them to acquire to reach year over year. With that assessment and incentivization, the second piece should be mentorship. What I have seen is that we have different types of preventionists when it comes to personality types. You have those who are go-getters and they will automatically go out and feel empowered to seek a mentor. And then we have some who are also go-getters, but they're introverts and empaths. And so they don't know the tools of, I see something in someone else that I desire to have in me, but I'm afraid to ask, or I don't know what to say. And so how do we empower preventionists who are new in the field to seek mentorship? Do we have an already pre-built methodology set up in our larger organizations? Or do you already have that also set up within your workplace? I am a firm believer that I'm sitting where I am because of mentorship. I was taught by my very first mentor as a sophomore when I flunked out of nursing school and got into health education that I needed to have a mentor. And this was her famous words: you need to have one who looks like you and one who doesn't. Each one will give you something that is different than the other and help you to navigate in the spaces that you work. The one who looks like you is the one that you don't have to explain much to. Your advocate, the person who helps you to find your voice, the one that you sometimes can cry and lean on to, and will also push you. The one who doesn't look like you will also do the same, but also should be your ally and your agitator, who will speak up for you in rooms too. But also, what I have learned is the one who didn't look like me, also to help me to see things that when sometimes I couldn't look beyond my own lens. And it took them to sit there and check me and say, I understand that you feel like you're hitting this glass ceiling, and you are. I need for you to see the other side of the coin. Because we had built that amount of trust with each other that they can also sit there and say, yes, and. Both of them have been important to me throughout my career.
I'm absorbing that idea of having two mentors, the one who looks like you and one who doesn't. And I'm just loving the concept of that and how you've explained it, where one, you're going to have a natural affinity with one mentor. And you know, the word mentor, to me, it's a loaded word for me personally. To me, it feels like a lot of pressure.
Yes.
And I've used that word, you know, in my mentor. A slight anecdote that somewhat relates. So in a previous life, I was an athletic coach of a particular sport, bowling. For those that don't know my other life.
I love bowling.
Yeah. And I was coaching both high school students and college students. And in the high school realm, I had a team I was coaching, and there was one student in the league, and it's not like I ignored him, but he wasn't really in my sphere of the team that I was coaching. And I noticed that he and his parents were coming to tournaments that I was competing in. And just on an aside, his mom said to me, "You have no idea how much our son looks up to you." I take that with me from that moment on. What it said to me was, you can be a role model or a mentor without even knowing that you're being a role model or a mentor. I have a very good friend who has, not in this field, he has his own podcast, and he has this great saying that your brand is what people say about you when you're not in the room. And it's like this whole idea of mentorship and role modeling is you really can be that, and you don't even know that you are. It's just how you carry yourself, how you act, and the knowledge you impart. It's just when you brought up mentorship, that's what I thought of.
One thing that when people ask me to be their mentor, number one, I have an application process. And people are always like, "Are you that uppity?" I said, "No, I'm never that uppity."
No,
But
but I am. I want everything documented, so I do.
yes, I like it documented, but there's one important question that I have on there. It's like my question number 5. And that's where people get stumped at. And I tell them verbally before I even send it to them, which is, what are you going to provide for me? Because mentorship is bi-directional.
Hmm.
I said, what are you going to teach me?
Hmm.
And it stumps them every single time. I said, somehow we have created a society where this mentorship is more hierarchical. Yes, there is something in me that you desire that I am supposed to impart onto you, but it's not some type of like king, queen, pauper type of thing.
Mm-hmm.
There is some type of slight hierarchy. I said, but mentorship is bi-directional. I said, you are supposed to teach me something too. And I said, what is it that you have in yourself that you're supposed to teach me? Because this is a transactional relationship. It's not more of this is the cup and I'm constantly pouring. I said, because that is a relationship in which this is a win-lose. You're winning and I'm losing everything. And right now, where I am in the season of my life and career, my cup cannot continue to get emptied that way.
Mm-hmm.
And I said, if you're not able to answer that question, I said, you need to circle back. Because that's when, from an emotional intelligence standpoint, you have some work you need to do on self of what do you have to contribute in this space, in place, in this world, in your career, because you're not an empty vessel and cup. I'm not just pouring. And so I often have to remind people that yes, mentorship is for growth, but you also have something already in yourself. And what is your elevative speech to win me over to be your mentor?
Mm. It's a great interview process.
It is.
In a sense, because it is a relationship, and all relationships have to have a give and take.
Yes.
So I mentioned at the top of the episode that you are my 3rd VP in a row on this, and I'm going to ask you similar question that I asked Oliver Tacto a couple months ago and Lolo Hong last month. Since you're in a similar position, what are your thoughts on how we as a field can transcend alcohol and drug misuse prevention from being solely a student affairs issue to being a broader institutional issue?
Okay. Brain, give the short version. Okay. Um,
I know I could do a whole episode on this. I know.
yes.
I know.
Number one, we have to change the language. And how I change the language is that wellness is student success is wellness. We are one and the same. And if we want to ensure that we are constantly at the table past this current pandemic of mental health, we have to ensure that this is not just a temporary Band-Aid fix.
Mhm.
How the conversation narrative has to change from prevention and mental health needs to be that when we're having conversations about enrollment management, when we're having conversations about student success, retention, and graduation rates, if your wellness professional, your chief wellness professional, chief well-being officer is not at the table, you're already doing your campus a disservice. When we're talking about the culture of care for your campus and university, it has to start prior to the students entering into the campus. And I said this even at the previous online conference. No matter the demographic of student coming onto campus, if we are removing ourselves and not coming from a place of privilege, we are ensuring that we have at least a snapshot of who our students are prior to coming onto campus. So we can create a personalized pathway to get them to navigate it into care. Because the place of privilege says that we are automatically assuming that they are well, and two, that they will route themselves. That is privilege. Whether they are coming from low socioeconomic status, first gen, or they are well-to-do, that's a privileged assumption. And so prevention says that we do a brief assessment, we assess them, we navigate them, we give them a personalized pathway and get them where they need to go. That same data will also help us with what? Forecasting, preparing, as we once again generate data year after year. It also helps with preparing for orientation. Sometimes we can get re-prepared. It can also help us with early intervention at orientation, weeks of welcome. And then also it helps us with realigning programming for those first early parts of the semester. And then in the long term, it helps us with larger strategic initiatives and building out strategic planning for the entire campus. How are we working collectively together from financial aid, financial wellness, undergraduate studies, graduate school, international studies, to help with our larger campus? Because if we're trying to increase enrollment, we can't recruit them and have no way to, once again, have a sense of belonging. We can't retain them if we don't know why they're leaving, when we know that over 30 to 40% of students nationally leave for some health and medical reason right after financial. So we have to do this collectively together if we're going to have a well campus. And then most importantly, the ad hoc piece, well faculty and students equals well faculty and staff equals well students. We can't forget about the other side of the coin.
Yeah, the whole campus.
The whole campus.
I mentioned cultural competence being one of the foundations of the strategic prevention framework. The other one is sustainability. And what you've been talking about, Sherrá, in your response, speaks to how the more successful campuses have sustained their efforts is they've been able to make the case for senior leadership all the way on up to the president that the work that we do in prevention and mental health connects to enrollment management, connects to student retention, connects to graduation rates. It's what you were just saying, this whole piece is, that's how we transcend, is making the case that everything that we do connects to just about everything else on this campus.
Yes, correct. It's not just mental health. And I keep telling people the students who are on our campus are post-COVID. So it's not just mental health, it's emotional health and social skills. That's not just mental health. It's the continuum of care. More neurodiversity, that's not just mental health. That is also chronic illness, that is also emotional wellness, and it's also health. And so we have to begin to change our language. And in order to change that language, that means we have to bring in the whole entire campus to support these newer types of students who are older and also who needs what we call out in the community wraparound care, which is not something that we've ever been used to in higher education because we're all siloed. and we don't share information, and we definitely don't share one EHR. Everyone has their own.
Yeah.
Mm-hmm.
So as we start to wrap up, I always leave the final question as the same question for every guest that I've had. And it's sort of like I turn the mic over to you, although the mic's already been turned over, so it's not like it's anything different. But it's the advice and takeaway question. What advice do you have for your peers, the professionals who are working to prevent alcohol and drug misuse among college students, as well as the students themselves who might be watching this episode? What advice do you have for them?
Never underestimate your story. Many of us have came and entered into this field because of the things we saw in childhood, whether it was directly affected us or through vicarious trauma, or the things that we've survived. Whatever made you come into this human service field of whatever the title may be, never underestimate it. Use your skills and your education and mentorship. The power of empathy and active listening can go a long way. We must build trust. We must utilize trust and care, and also with best practice to compliance and trying to build out equitable policies and procedures for our student populations and larger populations overall. Use your story to be advocates for the historically marginalized. And once again, keep focusing on prevention as a holistic issue, one that ties to the whole person.
Mm-hmm. Wow. So with permission, I'm going to borrow, I don't like to say steal, but use that whole concept of never underestimate your story. I do love that because as I've done on other podcasts where I've been guests on others and in interviews and presentations, my road into this field was as long and winding as the next person. I think I don't really know of anyone who specifically said, you know what, I want to go into the prevention field. It usually doesn't work that way. But, some they might specifically say, it's social work, and sure, there's a path. But a lot of folks who end up in the prevention space ended up, on a very long and winding road. And that is what I take away from that concept. Don't underestimate your story. And I've told my story in other ways. And it's part of, how I got here. And it's my history. And everybody has that. I think that's the whole point is your story is unique. And others can learn from it. And they won't take everything from it. I mean, that's not what it's about. They'll use it's like I say about going into a workshop at a conference. You know what? The 90 minutes you're in there, the 60 minutes you're in there, you're probably not going to use everything. Take it all in, throw out what you don't want to use, but keep what you do want to use. And I think that that's true of kind of any interaction that we might have. But I love that advice of whatever brought you here. Don't underestimate how that can influence others. I just love that. Sherrá, you've been a wonderful guest. I love the conversation and on topics that aren't always easy to talk about, and people don't talk about them. And I always say, you know what? Don't be afraid to talk about stigma. Don't be afraid to talk about cultural competence. Don't be afraid to talk about DEIJ. It's, and I know, like you said, not underestimating my story. I know that how I talk about diversity, equity, and inclusion, I can, but if I have someone looks like Dr. Allison Smith from Louisiana, who I do a lot of presentations, when we tag team like that, I think that it just is, I don't know, so if it's better, it is just more dynamic. Maybe that's what I'm looking for.
And both is needed. Richard, I've seen you present with Allison, also with my twin sister.
Yes.
Both aspects are needed. I can't say that one is can be done just alone. Of course, sometimes you can do it individually, but when you put it all together, it's like, the old nursery rhyme, put it all together and what do you got? You got magnificent, powerful, and very strategic driven workshops that hopefully will empower people to continue to go out there and to do the change. Because sometimes, the work that we do is hard. And so, yes, we cannot do this work without you and others like you too. We have to do it cohesively and collaboratively together.
That's so well said, and that's a great way to end on this episode. Again, Sherrá, thank you so much and for the work that you do. And to our viewers, thank you for tuning in to this episode. And you can see all of our previous episodes on campusdrugprevention.gov. With that, I'll say thanks for watching. Have a great day.